So this is my first case. So this is 74-year male with history of abdominal pain, vague abdominal pain. And this was the CT done in the ED. So here, this was without contrast. I don't know why they did not do contrast, but anyways, we can see hydronephrosis here on the left side. And as we trace down, do you see?
There's like some soft tissue thickening in the retroperitoneum. Does he have does he have a cancer history, he or she?
No, no history of cancer. And in this, again, we can see mild hydro and there's something.
I would say retroperitoneal fibrosis, IgG, lymphoma.
Yeah, or a bad urothelial that's like busted out of the ureter.
Yep, TC.
Yeah,
Or
so
mets.
Mets, definitely Mets.
Yeah, so definitely this is probably not an uncommon appearance for all the things that we just said, but the biopsy was kind of confusing, or I would not say confusing, but not expected, quite unexpected biopsy result. And this turned out to be squamous cell cancer in the
Of what?
They don't know the origin. So I don't know if it is like primary or some metastatic, but the thing is, in this patient, they have not done adequate workup. The patient is still pending for his PET CT to look for primary, but until now, we do not know the primary. So it could be, I don't know, the primary retroperitoneal squamous cell cancer is extremely rare. That's what I found in the literature. But probably after the initial workup, we might know what, if there is, like any other primary, and this is just a secondary malignancy. But yeah, whenever we see lesion in the retroperitoneum that is not arising from any specific organ, we always think of this retroperitoneal fibrosis, lymphoma, or probably germ cell tumor, or like those kind of things. But we do not think of the squamous cell cancer. So this was kind of interesting, but still not adequately worked up. So once the PET scan is done, probably I will show it to you again sometime in upcoming weeks.
Yeah, I would think that they definitely have to check their head and neck, because that's like the biggest place for squamous cell. And as far as I know, and maybe this is why it's so rare, we don't really have squamous cells in our abdomen, only as you get like closer to the skin. So like you could get urethral squamous cell, or you can get anal squamous cell, but usually in the abdomen, I don't think we have that skin kind of precursor cell. Although you can sometimes get squamous differentiation, but that's from like a very aggressive tumor.
Yeah, and I found some case report that talked about primary squamous cell carcinoma, but in the pelvic retroperitoneum. And almost all of them were female, and they were thinking, like from the cervical cancer, and most of them were post-hysterectomy. So post-hysterectomy, some of the cancer cells spilled, and then that resulted into pelvic retroperitoneal squamous cell cancer. But this patient is a male patient, so even that does not fit in this case. So we'll have to see. Not sure. Yeah, that's my
and also I think Rupa is saying we also see extramedullary disease like this sometimes in myeloma. So like like a plasmacytoma, the retroperitoneum can look like this too.
Oh, okay. Thank you. So I'm going to stop.
Aarti, would you be able to pause? Thank you. Okay, so this is a patient who has a history of renal lesion. Single face.
Kind of weird shaped. Normally RCC is like more round. That one looks like a triangle.
Oh, shoot, sorry. Here. Triangle, yeah. Yeah, that does look a little triangular on the coronal.
But it looks enhancing without fat, so I'm still concerned about an RCC.
Sorry, that was the the provided history. Okay, anything else?
I feel like if you're showing it here, it's not an RCC, but let me see it again. I mean, does it have that ice cream cone shape? So it could be like a lipid poor AML.
Yeah, sure. Yeah, exactly. So all of those things were raised. And I'm showing you this because of anchoring bias. Right? If patient has a history of RCC and you see the renal lesion, but then there's something else going on too.
Pancreas looks like pancreatitis with a duck sign, with like a, what do you call it? Truncated duck sign. So I'm concerned that there's an obstructing lesion in the pancreas.
Yeah, this is acinar pancreatic cell carcinoma.
Oh, oh wait. And so, what, do you know what the renal lesion is?
Clear cell.
Oh, got it. This is why you were bringing up the other day when I was showing my acinar cells that you said that you had an infiltrative one.
They can look
Not a
infiltrated.
mass.
Yeah. And this is one of them. So I feel like the pancreas is an incredibly humbling organ. See if here's what it looks like. Yeah, and I think the take-home message is, yes, we are anchored to the history and we can get kind of fixated on that and start getting into the nuances. But then in the background, there's a lurking kind of shark. And what this turns out to be a little minnow.
Nelly, I don't
Go
want to
ahead,
be too
Leah.
picky, but is this anchoring bias or is this satisfaction of search?
Maybe both.
Okay. I know that you're the QA master, so I just want to make sure
I'm not the QA
following the
master.
rules.
I only learn the principles and try to apply it. And what I find is that application, learning is something, but application is completely different. It's very hard. Right? You can have the knowledge, but to really understand it and practice it is something entirely much harder. Sorry, go ahead.
No, I always tell my residents to always look at the pancreas and follow it all the way to the pancreatic tail, because sometimes we don't follow it all the way out, you know?
Yep.
The splenic hilum.
And it's very subtle, right? I mean, super, super subtle, these findings.
Yeah. Anytime the duct is there and then it disappears, we have to look for a mass. Okay, Swachchhanda, you're back up.
So this is 60-year female, and patient had bleeding per rectum, and they did endoscopy and biopsied, and they found it to be rectal malignancy, rectal adenocarcinoma. And again, it has a lot of findings, but the main findings that I learned while reading this was peritoneum. For example, let's see the main findings. So here you can see a big mass, and this is the site of anal burst. So it's kind of low rectal cancer, and here we can see the thickening, and here we can see some images, and this image is showing the restricted diffusion, and this is like enhancing as well, multiple tumor deposits as well. However, the main finding that I initially thought, like when we think of the peritoneal reflection, I usually used to look at the mid-sagittal image and look for this kind of peritoneal reflection. And in this case, as we can see, the tumor is away, or at least the anterior peritoneal reflection is free from the disease. However, I learned that we have to look in the other planes as well, as we can see. So there is a big tumor deposit in the left side, and this gull wing shape appearance, which is also seen in the axial and also in the coronal plane. Here we can see this thing is touching the peritoneal reflection and even causing some thickening. So probably this might be concerning for the peritoneal involvement. And the other thing that I learned was whenever I used to see multiple tumor deposits or lymph node in the perirectal area, I would say, like some perirectal lymph node. But what I got to learn was we have to be very specific and say whether the whether the lymph node is within the mesorectal fascia. And if something is like outside, for example, this tumor deposit or lymph node is outside the mesorectal fascia, then we have to specifically say, okay, this is interiliac lymph node or, like extra mesorectal lymph node, so that when they do surgery and remove the mesorectal fascia through the CRM, this thing, probably they might have to do an extra dissection, or probably when they do not resect it, they might have to do postoperative radiotherapy to prevent the recurrence.
Swachchhanda, those are awesome points. I actually have some questions for you and or the group. The first is about your point about the tumor deposit touching the peritoneal reflection. Would you guys call that T4A if it's not the primary tumor touching the peritoneal reflection?
No, because
Okay.
I think it's been described only for the primary tumor.
Okay. And then the second question is, it came up in the SAR hands-on workshop where people were distinguishing between lymph node and tumor deposit. And I got very confused about the discussion, but do you guys distinguish between these, and how do you distinguish between them if you do?
No, sometimes it's really hard. It's really hard. But like, for example, in this case, it looks like a tumor deposit because it, kind of looks like the tumor. But it is hard. And I don't think we really make that distinction as much, though there is on the template, there is a thing for lymph node and for tumor deposit, two separate things on the SAR template.
Okay. Is the thinking that like if a tumor deposit has a worse prognosis than like maybe a lymph node?
Yes, I think the tumor deposit does have a worse prognosis compared to lymph node. But sometimes it can be difficult to differentiate between, like a smaller deposit and a lymph node. I don't know if you guys have faced the same problem or not.
Yeah. And I would say like my instinct here is to call this tumor deposit, but I don't know why. But maybe because it's bigger, it's rounder, it doesn't have like any lymph node kind of characteristic. And so I'd be like, okay, it's like a little metastatic implant nearby it, like a tumor deposit. But I don't know where I draw the line.
Yeah, actually, I was gonna ask the same question. Like when I read it, then I read it like lymph node / tumor deposit, but probably, like how do we differentiate between them? And the only logical thing that I can think of is probably the tumor deposit might not have the capsule, whereas the lymph node might have capsule. So, like the spread, even the abutment might be different with the lymph node if the capsule is intact. That's the only thing I can think of. But yeah,
I also think this, like if you see speculated margins like this one has, lymph nodes typically will not have speculated margins. Like you said, they will be very well defined or better defined. I think that's one of the things. And if the signal of the lymph node of the nodule is more like the primary tumor, I would probably call it a tumor deposit rather than a lymph node.
But this lymph node we are talking about is metastatic lymph node, correct? Doctor?
Correct. Even then, I think that, like, for example, in this particular case, this big nodule that you have is almost iso-intense to the tumor, and it has irregular speculated margins. So I would have called this tumor deposits. But it can be a challenge sometimes. The other, Aarti, since you brought that up, I think the other thing that we struggle sometimes is actually to see the peritoneal, the peritoneum itself. And sometimes it can become a real problem, even though there are like specific, anatomic areas where you say this is where the peritoneum is supposed to be. So just a question to the group: suppose you see something that is at the level of the peritoneum, but along the posterior wall of the rectum and not straddling the anterior part of the peritoneum, would you call it a 4A, or would you just call it going above the level of the peritoneum?
I find this confusing too, but one thing that has helped me, I would say in that situation, I would not call it a 4A unless I see it actually invading. Like, this is a beautiful example of thickening and invading that peritoneal reflection. But I agree with you, sometimes we don't even see the line there. And then secondly, if it's not actually invading it or thickening it, I don't call it a 4A. Also at that SAR hands-on workshop, they basically said, it kind of doesn't really matter because they don't actually think it makes it a worse prognosis. It's not like it's peritoneal disease, and it's not as bad as when it 4B where it invades other organs. And so it's almost the equivalent, like they treat it the same, and they think it actually has the same prognosis as like a T3. So they would still give chemo rads. So that alleviated a little bit of my stress of like, is this a 4A? Is it, you know, is it invading or just touching the peritoneal reflection, et cetera? Does that make sense?
Yes, sir. So one question probably I could ask you is, so this is the primary tumor, and here we can see this lesion. So would you consider this as an extension of the tumor with extramural spread, or another perirectal, you know, like necrotic lymph node? Probably I could. So the T2, so this lesion. Looking at this margin, I tend to think maybe it's, you know, like an adjacent perirectal lymph node rather than extramural extension.
I would agree, but I think this tumor regardless has extramural extension.
Yeah, definitely. Yeah.
But yeah, that does look a little. And then you always have to be careful. It's not an abscess. Sometimes if there's a perforation, there's an abscess, and you don't want to call that a lymph node or a extension.
Yeah.
This is a patient with a renal lesion. So here's your T2.
I'm only looking at the pancreas now.
Pre. This is a little bit of hyperintensity intrinsically. Let's see. And then the in and post phase. I don't think that's intralesional fat. It's just dark.
Do you have any subtraction images on for the post contrast, or can you put the pre and post next to each other?
Here's a subtraction of arterial.
Okay, so it looks like a hemorrhagic lesion that has true enhancement in it. So I'd be concerned for a hemorrhagic RCC.
This turned out to be a TF3 RCC. It's also known as XP11 translocation RCC. And they look like papillaries. They're too dark, probably a component of like hemorrhage. And they can be necrotic looking. They happen in young people, and they have poor prognosis. I don't think there's imaging features that's distinctive of this subtype of RCC, TFE3 gene fusion, or XP11. But this is one of the known sort of less common type of RCC, and they can mimic papillary. That's it.
Cool, but it's not a papillary.
No, it's a distinct. It's XP11 translocation. I think papillary. What chromosome is that? 17. It's a different mutation.
I don't know.
CMAT, I think.
Cool. Okay, Swachchhanda.
Third case. So the third case. So this is a young male in early 30s. So actually, I do not know the diagnosis. I just wanted your opinion. And once probably we get biopsy result, I will again share it with you. So only this finding is this big retroperitoneal mass, which is heterogeneous and also slightly enhancing, mainly on the left side, going all the way.
Teratoma. They need to scroll ultrasound.
So you think it's a lymph node?
I would
Without
give a
teratoma?
differential diagnosis. Yeah, I mean, it's elevating the aorta. So I would say, you said it's a man, so definitely a
Yeah.
scroll ultrasound, and then also I would include in there. I mean, lymphoma. I think lymphoma. Sure, I feel like lymphoma can look like anything. What else?
I like teratoma. Or some kind of nodal met. How old is the patient? or around.
Early 30s.
Yeah, I like that. Either a primary or like the met from a testicular tumor. One thing I learned from a case like this was that if you have to biopsy it, stay retroperitoneal, even if there's no bowel on top of it and it's easy to get to from an anterior approach. You want to stay retroperitoneal.
Sorry, what was the reason for that? I mean, it makes sense, but what was the reason?
Like if anytime you're biopsying something of a certain space, you want to stay in that space because that's how they're going to approach the tumor surgically. So they can go along your, and it would be best even if you talk to the surgeon and see where exactly they're going to approach it. So that if there's any like tumor seeding along the way, or, you know, you're staying in that retroperitoneal space. So you should do that also for liposarcoma, any kind of retroperitoneal sarcoma, but also for nodal disease. Same thing for retroperitoneal, like peripancreatic fat necrosis, like walled-off necrosis. You should stay retroperitoneal so you're not pulling the pancreatic enzymes into the peritoneal cavity.
The only thing is I see, you know, like this kind of, again, just looks like claw sign, but it also does not look like multi-lobulated, you know, like where we see commonly in the lymph nodal mass. So do you think it could be some sarcoma?
I mean, it could be, but I think Nelly's suggestion is like first to do the testicular ultrasound, and yeah, otherwise it could be a sarcoma. But I've seen these testicular nodal mets be sticky on the aorta. So usually they will give them chemo and try to shrink it, and then they'll scrape it off the aorta.
Yeah, this is my half case.
And we
Because I don't know
expect
the
follow-up.
I
We really await your follow-up
like the
after
use
your
of half.
retroperitoneal approach biopsy.
This patient has an elevated PSA. This was your T2 and then diffusion.
I'm going to call a friend from Arkansas for help. So I want you guys to speak up.
PIRADS 5.
ADC. Sorry, go ahead.
No, I said PIRADS 5.
Yeah, and then I don't think diffusion helps here, but no, I'll show you the diffusion anyways. Right there, it's enhancing. Good. So this went on to a biopsy, and there's no cancer. And there's a follow-up here. Here's your follow-up.
So just bad prostatitis, Nelly.
This turned out to be granulomatous prostatitis.
Oh, so like BCG or something previously.
That's right. This patient, it was idiopathic because the patient does not have a history of bladder cancer and has not had BCG administration, like you said, which we commonly see in granulomatous prostatitis. So in this case, it was probably idiopathic, and it completely resolved, or not completely, but it got dramatically better on all the sequences.
Nelly, so did the biopsy
5 months later, 6
granulomatous
months later.
prostatitis?
It did.
Oh,
Yeah.
cool.
Nelly, we still called it a 5 though, right?
Yeah, exactly. It's like, I mean, I don't think you can call anything else, right? I don't. I mean, so then in retrospect, like, well, what, you know, is there anything that would have, like, you know, directed us one way or another? And Mike, this was a case for my colleague Akira Kawashima, who's our GU expert. Let me find it. Hold on. He said, well, what about like there's cystic changes here that we see here a little bit. We don't usually see that with prostate cancer. So, I mean, like here, for example, right? So I don't know. I don't know.
BC granulomatous prostatitis can be like really T2 dark, or am I making that up?
Yeah, it could be really dark, I think.
Do you feel like that area around that cystic thing is like really T2 dark, like darker than a tumor? Like in retrospect.
Oh, I've seen dark tumors. I don't think it's darker than tumor. But what do you all think?
I think it's fairly dark enough for tumor. No?
Yeah.
Would we have called these in retrospect like intramural abscesses because they're kind of T2 bright and
Yeah. Let me show you that. I want to. Where's the
Post
DWI?
test.
Oh, pose. You want the post? Okay, I'll show you the post.
Also,
Can
it's
I-
interesting you do
Can we look at
You're
the DWI
doing-
first? Curious. Get
you're
restricted.
doing DCE, which we don't, or you're doing this like contrast map, right? We don't do that. Does everybody do that?
A lot of places do that.
we don't, Aarti. We used to make them do curves at first, but now
Yeah, we gave up on it.
yeah, I think visually, if you're already suspicious on T2 and DWI, DC only adds more. That's all right.
Agree. And you wanted, oh, this was like our super old, so we have like separate sequences, but you wanted DC, I'm sorry, what did you want?
This is what, Nelly, just
Okay,
to
good.
just peripherally enhancing, like
Yeah, it looks like abscess, yeah, doesn't it?
retrospectively, yes.
Yeah.
Nice, good for him.
Yeah.
Okay, so I want audience participation. This is my first case. These are courtesy of my colleague Hernan. So thank you, Hernan. This patient has previously undergone a gastric bypass. You can see the gastric remnant going to the through the gastrojejunectomy. This is the excluded stomach. So what do you guys think about this gastric bypass patient?
It's like obstructed looking, but what's causing the obstruction?
Yes, exactly. So, and then also you'll see that there is hydro of the right kidney, and that hydro sort of disappears right here.
It's like a metastasis or something.
Yeah,
To
yeah.
the retroperitoneal, like when the CBD is dilated, there's
Yeah,
something,
the biliary tree is also dilated. The CBD is dilated.
something obstructive going on there,
Yeah.
right there. Yeah.
So exactly. So we
Mets.
were concerned like this pylorus, antrum pylorus looks really thick, but maybe not like a tumor because you can still see the mucosa and the submucosa. There's biliary dilation. So is there an ampullary mass? And then
there's a
is
lesion
that
right there. There's like a hypoenhancing lesion at the end.
this thing right there?
That
Yeah.
thing.
Yes. Okay, so is there an like pancreatic head / ampullary mass? And then is that also extending into the retroperitoneum and causing hydro? So Nelly, or any of you, what would you do now if you're trying to biopsy this thing? This potential ampullary mass?
Can you go down? Let me see. I mean, I don't think you could do EUS because of the distorted anatomy. Retroperitoneal, you could, there's a window retroperitoneally, like paravertebral.
Oh, like
Percutaneous.
trans IVC?
Yeah. Oh,
like
that's
going to
IVC. I
IVC?
forgot about that. Yeah.
Some of our IR colleagues, no, some of our IR colleagues will do that. We didn't go first to that, but the problem is when you have a gastric bypass and you're trying to get to the ampulla, like trying to do our ERCP, there's a problem, right? You have to either do a rendezvous procedure where you go all the way down this jejunal limb, go back up the jejunal limb and get back to the ampulla. But anyway, so I wanted to just talk about what they did in this case. So first thing they did was actually they placed a G-tube into the excluded stomach to relieve the gastric outlet obstruction. So we see that there's a tube here. They snaked it through past this colon. And then they also did a percutaneous biliary drain that went through the ampulla. And they tried to do brushings and spy bites down here, but they still did not get the diagnosis. So what else can they do if they've gone through the biliary tree to get to the ampulla? Do you know, anyone?
I've seen people like they'll like for the pouches, they go through the pouch into the stomach.
Exactly. So, like basically go from the pouch into the excluded stomach, right? So that is what is called an edge procedure. I'm just going to show you. So this is really cool. So they can place a large bore stent, like an Axios stent, between the pouch and the excluded stomach, put their catheter through here, and then get to the ampulla and biopsy it. And that's actually what they did in this case. And they ended up getting ampullary cancer. There was a lot of stricture here, so they actually placed a duodenal stent. So I'll just show you. This is, I don't know if you guys can see it, but this is the Axios stent here. You can see there's a stent there. And then this is them basically going through the stent. They put a balloon through the stent. They put their ERCP through the stent, through the excluded stomach. They went over to the duodenum. They were able to get the biopsy of the ampullary cancer. And then you can see that the duodenal lumen was narrowed, and they placed this duodenal stent here through that axios. So this paper is actually really cool. They show that like this is called what's called an EDGE procedure, which stands for endoscopic ultrasound directed transgastric ERCP, EDGE. So that's one way to do it. But they show a couple of different ways. So I just wanted to show you. So here's another one. So this you can do like kind of like what they did in our patient where they put the G tube in, but you can actually put a larger hole into the excluded stomach and go in that way. This is kind of the same thing. But then, and then there's several ways to do what we call a rendezvous procedure. That's when you go through the excluded stomach, through the jejunal loop, and then go back up the pancreaticobiliary limb and all the way up. But these are really hard to do because you have to go all the way around. And often they might need to do a single or double balloon technique in order to have traction on the bowel to get it all the way through to this thing. So because this is so complicated and often unsuccessful, they're now in our place doing more of these other procedures where you're going directly from the gastric pouch into the excluded stomach. Okay, any questions?
Out after the procedure, or what happens to the stent?
It's just like when they do a cystgastrostomy, eventually they can just remove the stent and the hole actually closes off. Okay. This is just kind of a show and tell. This patient actually had some childhood urethral issues, had a long-standing Foley catheter, and ended up with a severe stenosis of his bulbar urethra. So just to review about the male urethra, we've got the prostatic urethra that is coming down from the bladder, then the short membranous urethra, then the bulbar urethra, which has a more bulbar appearance, and then the penile urethra here. This is not a normal appearance of the urethra, but this patient had a severe stricture of his bulbar urethra. And so what they did was reconstruct it using buccal mucosa, so the inside of the cheek. And they did a ventral graft. So they sometimes do a dorsal graft, sometimes do a ventral graft. In this case, we can see this irregularity of the buccal mucosa of this ventral graft. So they grafted it, and then they put a suprapubic catheter in for 6 months. And then we basically did a VCUG. So we filled his bladder with contrast, and then we had the patient void. We saw that the graft looked nice and good, just like the normal expected irregularity here. There was no leakage. And this penile urethra is also, he has sort of a long-standing sort of stenosis of his penile urethra, but it wasn't short segment. It wasn't something that could be dilated. So this is not the normal caliber of a penile urethra, but this is what it looked like. And so he was able to void and everything looked good. So this is just a ventral buccal mucosa repair of a bulbar urethra stenosis. Using a VCUG. We could have done a rug, but given that we knew that he had this long stenosis of his penile urethra, we opted for a VCUG. So this is the next patient. They're 45-year-old. What do you see here? Anything? Okay, I'll scroll back through.
Bowels like
Thickened.
stratification.
Yeah, stratification.
Pre-fluid.
Dilation.
Venous thrombosis, portal vein, and SMV.
Perfect, perfect. Yeah. So we've got this expansile hypoenhancing clot in the SMV, splenic vein, main portal vein, extending all the way up. And we've got cavernous transformation here. Does anyone know the treatment for portal vein thrombosis? Or what you would think they might do in this case?
I know. I mean, I've seen our IR people go and try to recanalize it.
Yeah. So I was kind of curious, like what situation they would go recanalize it with, which they don't. So in this case, they went transhepatic, went into the portal vein. There was all this clot. They did mechanical and pharmacologic thrombectomy. And okay, and then this was the post. So beautiful.
That's
result.
amazing.
The SMV, the portal vein are open. So the reason they did it in this case is this patient does not have liver disease. They have ITP, so they're hypercoagulable, but they do not have actually underlying liver disease. So that's only about 10% of patients with portal vein thrombosis will not have underlying liver disease. And if they have an acute thrombosis, that's when they're going to be doing this portal vein thrombectomy. But if they do have underlying liver disease, it's a little bit more complex because those patients are at risk for both bleeding, like this thrombosis, but they're also at risk for bleeding because they often have low platelets. So it's a more complex algorithm. But basically what they have to say, do they have symptomatic portal hypertension, like, or do they have symptomatic portal hypertension like bleeding varices or ascites? If that is the case and it's not controlled by endoscopy or paracentesis, then they might actually do a TIPS procedure to try to alleviate the pressure within the liver and alleviate that backflow into the varices and ascites. But if there's no portal hypertension and there's a non-occlusive thrombus, they just do wait and see. If it's greater than 50%, they will do systemic anticoagulation. They will not actually go in and do this kind of thrombectomy. And then if they have portal hypertension, but it's controlled, they will also do systemic anticoagulation. So what I learned is that there's basically three options. Most people get systemic anticoagulation. If they have bleeding varices or ascites, they might get a TIPS in the setting of cirrhosis. And then if they're like my patient who does not have liver disease and they have an acute thrombus, that's when they might go do a clot removal.
I've also seen, go ahead.
What?
Is there any time frame, like normally if it gets more subacute or chronic, won't the vein itself start collapsing and becoming small? They kind of have to catch it at the right window, right?
Yes, that is a really good point. So they really want to catch it early on. So like if it's kind of been, it's subacute, chronic, and now it's starting to like the venous and actually one other point is that cavernous transformation happens immediately. So that like your liver already is getting a buffer response. It happens immediately. Those little varices already exist within all of us. They're just a venous plexus around the portal vein, but they really want to catch it early on so that they can try to get it out. And there is a rate of recurrence. I don't know exactly what the rate of recurrence is, but they will actually leave a catheter in and anticoagulate them for like several days, and then they'll shoot an image again and then remove it. But they really want to catch it in the acute phase.
I've seen in our like transplant patient population, cirrhotics who have portal vein thrombosis, our interventionists will go in and recanalize it as well. And I think it has to do with reestablishing the anatomy so that when the patients get a transplant,
Yeah.
Okay,
so that's one other complex area that I didn't cover, which is that if they're a transplant candidate and it's going to affect the transplant, that is a situation where they will do it. So they will do it in cirrhotics sometimes, but it's trickier because they have this like, bleeding thrombosis. And also in cirrhotic patients, it doesn't really change their long-term outcome. So even if you recanalize it, they still have just as bad a portal hypertension. It does not change their outcomes. But if it will change, if they're like going to be getting a transplant sometime soon and it would change that, and they think it's acute enough, then they will go in and take it out.
Yeah, I think it's supposed to make the actual surgery like a little bit easier.
Yeah, because then they have something to
yep, reanastomosis too. Yeah.
Okay, and then this is the last case. This patient, this is their liver, and this is a right upper quadrant mass. I'll show you the arterial and the venous phase. You can see there's a lot of vessels around the mass. The mass has a core of thickened enhancement around it. It's got gas and fluid inside of it. It is involving the liver. I'll show you the coronal in a minute. So, and then this is the venous phase. So just putting them side by side. Let me just move them side by side. Oops. Okay. So what do you guys think? Or do you want me to show you the coronal?
I love the coronals.
Okay.
I
Trying to
think
figure out where it's coming from.
Yeah, that's like, that's a major question here.
Is it a gist from somewhere that's invaded the liver?
So Rupa, that was my exact thought. I was thinking, especially just like to be centrally necrotic. They like to erode like into the mucosal lumen and have air within it. And I was thinking, for example, maybe it could be a, where is it? A duodenal gist, like very, very exophytic one. Because the duodenum is sort of intimately associated with this edge here. It looked to me very exophytic from the liver. One point is that this patient does have a history of chronic liver disease and hep C, and you can see that there's some morphologic changes. And you could say that there's some washout here. Anyway, this was biopsied and this turned out to be HCC. So my teaching point here is that HCC can be extremely exophytic. I don't know if this like basically started here. And it can also erode or invade, you know, the bowel and end up having air within it. So if you have that chronic liver disease. So anyway, I was tricked by this one too. Thought it could be a gist, and this turned out to be an HCC.
Great case.
Yeah. And maybe one clue on one of my colleagues was saying like, oh, look, a branch of the hepatic artery is feeding it. I still wasn't convinced by that because I thought like, you know, any tumor can kind of parasitize vessels from like other organs. Like you could be even parasitizing from the nearby kidney. So I wasn't convinced by that. But anyway, this turned out to be an HCC.
And the gas is from, you said, bowel invasion?
That's what I think. See, it's basically like intimately associated with the duodenum right here.
Yeah.
So I'm presuming it's due to the bowel invasion. Yeah.
Wow.
Okay, that's it for me. Anyone else? Okay. And next week we won't have conference because we will be in person. I'll see you guys at SAR.
See you all.
Bye, everyone.